Alright, so this is the link, Fatima. Now give me something more interesting about motor neuron. What is the thing that usually not affected? Sensory? Normal. Is there any bladder's problem or incontinence? Normal, right, so it's also normal. How about the cranial nerve? What do you think, guys? Could the cranial nerve affected or not in motor neuron disease? You know, you have cranial nerves, right, which is basically also motor. Could the cranial nerve affected? Yes, so cranial nerve, guys, definitely will be affected, but sensory normal, bladder normal, cranial nerve, it's sometimes if they also prototypical, they say everything normal, but it's not normal like sensory and bladder. Sensory and bladder, you can say 100% normal, but is there any swallowing difficulty in speaking, difficulty? Yes, so basically you will see maybe patients have difficulty swallowing, chewing, so the facial, so basically cranial nerves, positive or negative, so could be affected here. All right, in motor neuron disease. Weakness, this is the last one, which is basically muscle weakness. Reflexes, normal. So I'm talking about muscle problems. And in muscle regarding neurology, guys, you have two diseases. Maybe you have big one, which is myasthenia gravis, right? So you have, if the weakness increase, so you can say weakness increase during the day or improve during the day. So increase during the day, we are talking about myasthenia gravis, and improve during the day, we are talking Eaton-Lambert syndrome or Lambert-Eaton, right? So Lambert-Eaton syndrome, which is the opposite. I mean, the patient is fine, but so the patient is not fine, but during the day the symptoms will be improved, or I think Lambert-Eaton. Now give me the pathology, or not the pathology, the location, which is also I think easy. What is the location of myasthenia gravis? What's the problem?
Acetylcholine receptor antibodies.
So it is post-synaptic problem, right? What is the problem in Lambert-Eaton syndrome?
In the calcium receptors?
Which is basically presynaptic. So here, guys, here you have presynaptic and presynaptic calcium receptors, and you know, both of them, the problem basically it's antibodies. So antibodies attack presynaptic region, and antibodies attack to acetylcholine. So both of them, guys, antibodies. So this is important pathology-wise. Now, how about the reflexes? Usually normal, usually not affected in myasthenia. Although they say it sometimes in Lambert-Eaton, but you know, general word about the reflexes in muscles, because you are talking about muscle disease. So reflexes, guys, if it is affected, it will be maybe though, but usually I like to say it's just normal. I mean, make more sense. Now, yeah, because it's muscle more than the nerve. Although I feel in Eaton-Lambert sometimes prototypical example is low, so I'm not sure if it is just normal. Sometimes I think low in Eaton-Lambert. So you diagnose myasthenia in this patient. Second test. This is maybe important initial test and test of choice here usually in myasthenia. What do you think, guys? Yeah. So you diagnose myasthenia. Next, how you'll diagnose this? You think clinically it's myasthenia. What you will do to say this is myasthenia, guys?
Edrophonium?
Can we check
Also of the acetylcholine esterase?
Yeah, what will be that one? I mean, it will be maybe confirmatory, right? Yeah,
Yes.
that maybe will be confirmatory, which is the last one, which is a good answer. I think the initial test, guys, I don't think hydrophonium, nobody will use it nowadays because it's really have a high percent of false positive rate, so I don't think hydrophonium is the answer, really. What I think, yeah,
Test for antibodies?
it will be the confirmatory, but I think the initial one maybe, which is EMG, right? So initial one, electro.
Okay.
Right? To see what you will see in EMG of myasthenia, basically, you will see decreased response, right, with the stimulation. So when you will give stimulation to the patient, basically you will give stimulation. After a while, the response will be decreased, which is basically this could be indicate myasthenia. It's not a specific, but could be indicate myasthenia. So I think this is the initial. What next to diagnose this is 100% myasthenia will be the confirmatory. Someone said acetylcholine is a problem. So basically, guys, maybe you'll go with acetylcholine receptor antibody. You will just mention the receptor. This is really most specific test. Okay, this is most specific to see the receptors. Now you see the receptors and you are 100% sure that's myasthenia. What is next?
Treat.
Give a treatment.
Before. Which depends on the treatment. That's why you have to see it. If it's present, it depends on the treatment. Yeah, guys, what is next?
Do you check for thymoma?
Right.
Do CT or
So
something?
basically, we'll do CT scan to check if thymoma, because this will do CT chest to check thymoma, because if thymoma present, that will go with just take it out. Right? It will be the treatment. So before you determine the treatment, you go CT chest. If CT chest positive, thymoma you will treat. If CT chest, I mean, you will take it out because it's thymectomy is the answer here. So as we said, this is CT. So you'll go if it is positive, maybe you'll just do surgery, right? If it is negative, you'll do what is the drug of choice, by the way? Treated, which is acetylcholine receptor, acetylcholine esterase inhibitors. Right,
Pyridostigmine.
which is pyridostigmine, which is easy, but it is usually symptomatic relief. So that's it. This is pyridostigmine, and here is the surgery. Is there any role for steroid? Any role for plasmapheresis? Any role for IV immunoglobulin?
I don't think so.
Yes.
Yes, there is a rule for
right. So there are there are rules for all these guys. Acetylcholine esterase inhibitors, patient not improved after acetylcholine inhibitors. Now there are rules, but I don't think the choice will be which one is better than the other. But I think plasmapheresis. Hello, yeah. Now it's better.
Is that yours, Rab? The fire alarm?
No, I'm not cooking. So first, maybe you can use steroid, or you can use immunosuppressant therapy. So you can say steroid or immunosuppressant therapy. And I think last resort will be plasmapheresis and even sometimes IV immunoglobulin. But I prefer plasmapheresis and IV immunoglobulin for a kind of acute treatment. That's why I do it like this, and this is a kind of chronic treatment. But again, I don't think these details in myasthenia gravis. Myasthenia questions, I think EMG is important, receptor antibody is important, and CT, sure, CT chest is very important. Alright guys, any question? How about creatine kinase in those patients? Although I will talk about muscles in more differential, maybe at the end of the lecture. How about creatine kinase here as a lab test? Do you think creatine kinase will be increase or decrease or not related?
Normal, I think.
Yeah, those patient creatine kinase is normal because it's not the problem in the muscles is it's not muscle problem original, it's a neuromuscular disease. That's why CK normal. Alright, which is creatine kinase. Now, you give those to the patient, and then the patient, let's say, after a while, come to you suddenly with the following features. So he has fever, he has decreased blood pressure, and let's say he's have cough and desaturation, SO2 is 80% or 85%, and he's really weak. What is the next for this patient?
Stop the treatment.
You need to give something now.
Consider intubation.
So here, guys, you next basically two things: intubation one, and someone said stop the treatment, and which is also right. So basically, you will do intubation first, and then you will stop the drugs for a few days. Why? What's the diagnosis here? What's the problem?
Maybe poisoning.
No.
Yeah,
Yeah, what is that?
the crisis.
Yeah, this is a crisis.
Crisis.
Right, so this is basically, is it myasthenia or cholinergic? I don't think also these are important for two, but just in case. Is this is myasthenia, usually it's myasthenia crisis or cholinergic crisis. Clinically, it's so hard, guys, to differentiate it. You remember in pharm in step 1, we used to differentiate it by hydrophonium. We'll give hydrophonium with the patient improve. That means myasthenia crisis. If the patient don't improve, that means cholinergic crisis. But I don't think they will ask about this stuff because nobody uses it anymore. But here, usually you will go with the crisis as a pathology, whether it's myasthenia. Usually it's myasthenia. Or usually it's because it's long term. Sorry, it's cholinergic. That's why you will stop the drugs because the receptors already desensitized. So crisis, I think, one is cholinergic, right? For you, I don't think the question will be.
Riyadh, Alan need to be called.
He's here, right? Alan, you here?
Yeah, I got the call. I lost my connection just
Alright,
for a second.
okay, no problem. Thank you, Radwan.
Hello.
We get another one that, other than Ali, well, people today are active too.
Yeah, I'm here.
The little one is here. She's playing and screaming and yelling, so I have to stay on mute. Sorry, guys.
Oh, okay, no problem.
Yeah, excuse me.
Yes, Zahra, go ahead. I hear you.
The crisis, would you repeat it, please?
Yes, sorry, your question. Oh, yeah, the crisis. It's farm point, guys. I don't think they will ask you, but I don't know if you are interested. It's basically patient will come with severe weakness and tiredness and desaturation. So this is a clinical one.
Sorry, I couldn't read it.
Yeah, wait a second, yeah. Now you hear me or not?
I hear you, but the crisis, what did you
because also I talked about that quickly. So crisis, either you will have problem with too much treatment, so it is over treated, or under treated. Alright. In over treated, you will desensitize the nicotinic receptors. So these nicotinic receptors will be desensitized because of too much treatment. And when these desensitize, that means the patient will not respond to the drug. So we'll give the drug now, which is pyridostig, mean there will be no action, right? Because these are not working. So nicotinic receptor desensitization, right? So drug is not working, and I think this is most common presentation, which is cholinergic, maybe cholinergic crisis. So it's over treatment, the drug not work. Under treatment, the drug work, but it is low dose, so there is no problem with the receptor. So the receptor is okay, but the problem with the drug will low. Okay, so drug will low and receptors are working. So you can say receptors. What's going on here? Please, the one that you just joined, make it mute. Alright, so if you have over-treated, the drug is okay, but the receptors are too much desensitized because of the drug. Basically, you can say drug high here. So the answer will be stop. The answer for that will be stop and wait, while the answer for that will be increase the dose. But these are very hard to do in a clinical practice. So in a clinical practice, what are you doing? You just stop and wait. Nobody will use hydrophonium test anymore, but just in case you'd like to know what is hydrophonium, basically if you give hydrophonium to this patient will be able, so here you will see improvement after hydrophonium, while there basically no improvement because receptors is damaged. I mean the receptor not damaged, sorry, desensitized. So you need a few days for the receptors to recover. Alright, Zahra? Alright guys, question? Now clinical point. Guillain-Barré syndrome, myasthenia gravis. There is specific things here basically, which is diplopia, right? Muscle problem. Guillain-Barré syndrome paralysis is interesting, which is ascending. Now give me a disease, why I put here, give me a disease that he has a kind of these two features with some maybe mild differences, but there is a disease, guys, that have some kind of paralysis and some kinds of diplopia. That's why we'll make it in the middle. Well, what's the problem? Anyone remember?
Guillain-Barré syndrome?
No. MS could be an answer. MS could be an answer for any diseases. What else? What else? It's not a disease. Basically, it's poisoning. So what do you think?
Botulinum.
Right.
Okay, botulinum.
Yeah, so botulinum, which is botulism. So you can put botulism here. Patient presented with diplopia. Presented with paralysis, but this paralysis is what? Usually descending paralysis. So usually descending paralysis. What else? It's also important in botulinum because it is a problem with acetylcholine, right? So you'll inhibit the acetylcholine. So what do you think the pupil size in this case will be? Mydriasis, right? Pupil size. While in myasthenia gravis, guys, you don't have problem with the pupils. I told you, usually the cranial nerves are not so affected. If it is affected, will be maybe hypoglossal or glossopharyngeal, not the down one. So pupil size is normal. So pupil, you can say pupil size, normal. So this is how you'll differentiate, because these are very important in your questions. You'll see all of them, and especially the diplopia questions are kind of irritating. You don't know why is that. Although I feel in the clinical case it will be easy to differentiate, but just in case. So botulism, basically botulism have one thing in common with Guillain-Barré, so it's paralysis one, but don't forget it's descending one, because in Guillain-Barré it's ascending. And myasthenia gravis is one thing also common in myasthenia, which is diplopia. But also don't forget, because you are dealing with acetylcholine and inhibition of acetylcholine, that's why you will see mydriasis, no meiosis or not normal. As we said, what else? Yeah, that's it about these four. Yeah, these, I really hate these four because I don't know how to make it in one big category. I think it's easy to know them, but not easy to make it, in just be one big category. I think I have to think more to make all of them in one big category. Like, so we finished, guys, myasthenia gravis, we finished multiple sclerosis, we finished myotrophic lateral sclerosis, and the last one is whatever. So we're done with these stuff here and there. let's go to our major also topics. So we still really have a lot of major topics. The major one now is seizure. It's very hard.
Can I ask a question?
Yeah, go ahead. Yeah, go ahead, Michael. I hear you. Do you want to ask something?
I wanted to, for the Lambert-Eaton syndrome, can we also check the lung to see whether there is malignancy?
Sure.
Because sometimes we always associate the malignancy of the small cell carcinoma of the lung. Do you want to do that?
Sure, and this will be a question, by the way, the next. Yeah, sure. After EMG, also you will do CT chest to make sure it is not lung cancer, because I think the most common cause is small cell lung cancer. Yeah, sure.
Okay.
Yes, sorry, I didn't talk about, but sure. Now, seizure, guys, it's two different questions. Either seizure not type, I mean, he will not ask you the types of the questions, maybe, or types of the seizure, or maybe he will ask you types of seizure. So, this is how you will study it. You will study according to the types, or you will study according to just the clinical. Now, the type will be the next page, so let's talk about the clinical. I'll give you a scenario. Seizure patient, drug of choice. Quickly. This is easy. Benzodiazepine. I don't care about the cause. I don't need to know. Just give them.
The first one is diazepam.
Yeah.
Start with benzodiazepam and
right. Just go. Just go with benzodiazepine, guys. Because it is seizure, and because maybe either it's a new one, you don't know exactly. But any seizure patient, you will not give, by the way, just benzodiazepine. You remember when I told you any problems, altered mental status, acute, you will give glucose too, because make sure this is not hypoglycemia. Maybe you need also to give naloxone to make sure this is not morphine problems. So this is usually general, but I think, I think the answer will be just benzodiazepine, which is very easy. Now, you give benzodiazepine, still seizing. Now, still seizure increase, you have two options, guys. Look, if the patient is still seizing, now, then go to the second clinical, which is basically, responsiveness. Check his response after seizing. So I will say, why make it wrong 2 times? So I will say go with second with responsive or not. If you will see, guys, there it could be the patient unresponsive plus have some twitch or jerk, does not necessarily have tonic clonic. So maybe the question will be just the patient unresponsive, but even if it's unresponsive, so basically unresponsive, which is negative response or positive response. If the patient negative response, but he's still seizing, what's the treatment of choice here?
You go with negative. You go with phenytoin.
No, he's unresponsive. No, he's unresponsive. That means
intubation.
Yeah, intubation, guys. This is intubation. He's unresponsive. You have to intubate those patients to protect the airway. So here you will not go with the classical phenytoin, phenobarbital anesthesia. Hey, there is no time. There is no time to give phenytoin bolus. He's just unresponsive. He's really he will get desaturation. So you need to protect the airway. Now, with the patient responsive, in this case, you will go with the one that you like, which is basically phenytoin IV, phenobarbital. I think the question just about I don't think phenobarbital will be the question, which is the next, but I think just phenytoin, usually most of the patients are okay with phenytoin. So this is important, guys. So you will not start anti-epileptic drugs unless the patient is responsive, or maybe after intubation also goes with anti-epileptic drugs. Right? So when I say patient still seizing, that means I'm talking about status epilepticus. Give me some features about status epilepticus. Timing. Give me time. How long? That's the patient that I can say this status epilepticus.
Can you continue?
Yeah, continuous usually.
More than 30 minutes. More than 30 minutes.
I
Up
think
to 60 minutes.
I think more than 10, 30 would be too much. more than 10 minutes. Alright, so I can say this status epilepticus, or maybe not responsive to treatment. So this is also status epilepticus, not response to treatment. You give benzo and not response to treatment. This is also status epilepticus. So we're done with this point, which is response intubation. Most of you guys are fine with benzodiazepine, but some of you, for some reason, this intubation is important here. He's unresponsive. Maybe he will give you also unresponsive with some kind of cyanotic, just to guide you. Please don't give medications. There is some emergency situation here. All right. So this is part of the seizure. Now, of the clinical seizure. Now, what else also clinical seizure? Give me what you will order for this patient. It depends on, because really this is interesting. After seizure, guys, go with temperature. And then it will go down, sorry, no space. I don't know, for some reason, my brother just told me, when I email you guys and email you page 135, I don't know, in my system page 2 will not show up. I don't know why. So guys, any seizure, go with fever first. Check, because this is clinical, right? So we'll check the temperature. Now, if you will see the temperature high, or if you'll see the temperature normal. Now, if you'll see the temperature high, what's your differential? We'll go CSF. And look at the CSF. You have 2 CSF findings. If you'll see the bacteria in CSF really high, so I will not talk about the details of CSF because it's not the time here, but if you'll see the bacteria of CSF is really high, or maybe you will see, not bacteria, sorry, I mean polymorphonuclear cells, sorry, I mean here, polymorphonuclear cells high, or lymphocyte high. If I'll see polymorphonuclear cells high, that means the patient has meningitis. So meningitis could be presented as seizure. Now, if you will see lymphocyte high, you have 2 differential, which is that's why I want to make a case here, because this is very high yield. Go to red blood cells. If you will see red blood cells normal, or you will see red blood cells high. If you will see red blood cells normal, this is viral meningitis, which is not the question. Here is basically your question, which is classical. Any seizure patient plus fever plus red blood cells high plus some features, which really I don't know how to memorize it, but the features usually you can say positive, negative stroke features. So here you can say, wait, let me, before I will go to diagnosis, positive, negative stroke features, guys. Like what? Like aphasia, like paralysis. So you can say aphasia, paralysis, whatever. Dysphagia. What's the diagnosis here, which is the last one, which is, this is prototypical. This is very classical scenario. Any seizure patient plus fever plus some kind of weakness, diagnosis would be what? Hello, guys, we talked about that even in step 1. Fever. What? Hey guys, it's easy. Weakness. Okay. I mean fever and neurological symptoms. A fever and neurology. We're done with meningitis. What is the opposite of? What's the brother of fathers? Or
Brain abscess? Is that
no. Abscess. You will not see lymphocyte high. The brain abscess, I don't think you will see lymphocyte. You will see also polymorphonuclear high. So you are right. Maybe you can put here differential diagnosis.
Subarachnoid.
I don't think subarachnoid you will see lymphocyte high and some stroke-like features, guys. Subarachnoid present as headache.
Also,
What else?
this is fungi.
No. Hey, no, sure, will not present as aphasia and paralysis.
simplex encephalitis?
Very
What
good.
else? Stroke?
No, very good. Encephalitis, guys. HSV encephalitis. Very high yield, please. Although maybe we can talk about that in ID, but it's because here I'm talking about seizure. It's very high yield. I mean, encephalitis, viral encephalitis presented as seizure stroke picture. Viral encephalitis, seizure, stroke pictures. So don't forget this one. So this is your approach of the seizure. Now, if you will see temperature negative, which is basically normal, now we will go with a lot of stuff. Things that usually we forget: UDS, which is urine hydroxyurea. Usually you forget that, urine hydroxyurea. And you know, you will go with CBC, you will go with PNP, means creatinine. So you'll check everything. EKG to make sure no arrhythmia, chest X-ray, plus what? Something missing here also, you need to check it, which will be maybe a question. What you need also to order. You order all of these guys and it's negative. What's next?
CT scan?
Very good. Is it contrast or without contrast?
Without contrast.
Right. Without, guys, the only time that you order the contrast when you are checking for tumor or infection. But here, basically, why you order without contrast? To rule out what?
Hematoma or something.
You to rule out
It can also
not subarachnoid, basically, to rule out intracerebral hematoma.
intracerebral bleed.
Yeah, intracerebral bleeding, usually. Okay, guys. So this is your clinical approach to seizure, not because I told you seizure questions is very high yield, but usually either just the clinical approach, which I feel sometimes students are weak in this approach. Students usually take time to remember partial, complex, generalize, and spend time drug of choice there and there. But usually, it's not necessary. They will ask you the types. All right. Any question for this approach?
Yes, Dr. Riyad, quick question.
Go ahead.
The CT without contrast, are we using it when we suspect somebody has intracerebral hematoma because blood itself is a contrast material?
No. Maybe it's interesting, but you know why you need to make a contrast? Contrast, basically, you give a contrast to wherever the CT chest, brain, you give a contrast just to enhance the lesion if you have a lesion. To see the lesion,
Okay,
just,
I understand.
yeah,
Thank
just
you.
to see the lesion properly, which is in case of mass, tumor, or abscess. Always, guys, contrast means tumor or infection. Now I'll go with other types, which is the thing that you are good with. So, yes, guys, now your patient have epilepsy? Then the second thing, is it partial or generalized? So how you will know it's partial or generalized, guys? This is your time. You're okay with these, I guess. Give me something about partial.
partial loss of consciousness.
Loss of consciousness? So in partial, you will go second equation, conscious level. If you will see the conscious decrease or the conscious normal, right? So if the conscious decrease, or the conscious normal. If the conscious decrease, your answer will be what?
Complex partial.
This is a complex. If the conscious normal, your answer will be what?
Simple partial.
Simple partial. Now they call it partial because part of the brain is affected. Alright, guys, even if the patient have movement problems, usually the movement is not generalized. So how we'll make it these again, clinical stuff. Why they call it partial? Because it's localized. How I will know clinically this is partial? From the movement, maybe. In case of simple, usually the movement is unilateral and transient. So even the movement is localized. So you can say here a movement unilateral, like for example unilateral just jerky movement, or unilateral tonic-clonic movement, usually unilateral tonic-clonic movement. This is a simple. How I will know, and plus conscious I think is the most important thing, will be normal. How about the second one? We just say the conscious is decreased, and basically those patients, they have post-ictal state. I mean, they will be weak after the seizure. Alright. Sometimes there is something called automatism, which is usually lasted 1 or 2 minutes. So it's usually, let's say, 1 or 3 minutes, maybe. It's a kind of patient doing purposeless involuntary movement. Like what? Like he's doing lip smacking, right? He's just you don't know why he's doing that, but this indicate, guys, complex problem. By the way, that's mean it's which is usually preceded by decrease in consciousness. Okay, maybe he become aggressive, maybe he's doing lip smacking, maybe he's doing that chewing kind of movement, or maybe he's doing just any movement, or repetitive movement, which is a kind of weird. You don't know what's going on because the patient is okay, but he's doing some movement. So this is automatism, guys. Goes with complex, goes with conscious. So I think the clinical picture will not so hard. He will give you a case like patient do like repetitive movement for 1 to 3 minutes, plus sudden onset. He just loss of conscious, and then with movement or without movement. I mean, with tonic-clonic seizure or without tonic-clonic seizure, not necessary. The problem here with automatism the clinical with automatism plus the post-ictal state and conscious decrease in conscious level. So this is very, it's not so hard to make it. While the simple one, you have movement problem and it's unilateral and the conscious level is okay. Now for generalized, the second question will be, is there any convulsion or not? If there is convulsion, if the convulsion positive, that means you are talking about tonic-clonic, or the second one, myoclonic. Okay, guys? If there is no convulsion, so what is the answer? Hey, what's the answer if there is no convulsion?
Absence.
Absence.
Right. Or petit mal. Absence. Or petit mal seizure. Usually those are school-age children, and they just stare into space, right? They just stare into space, look at that in space for a few, I don't know, maybe less than, I'm not sure, maybe a few seconds. Usually each episode, usually a few seconds. So usually you can say this is children. Interesting, stare into something. This is the second thing, and usually several seconds, so you can say second, brief episode, second. Is there any conscious level decrease? Yeah, sure. How about the postural tone? Is there any problem with postural tone, with incontinence, with post-ictal confusion? No, guys, here. So basically you can say the tone is still okay. The patient is not hypotonia. No post-ictal state. So you can say no post-ictal state, and the tone is okay. Yeah, it's usually okay. Just minor activity. Maybe just minor clonic activity, like just eye blinking or head nodding. Yeah, I don't want to make it here. I think it's just too much. Now, tonic-clonic, tonic-clonic, which is tonic phase, and then clonic phase, and then post-ictal phase. They will not ask you about these phases, but here, you have to know it's usually incontinence later on, and post-ictal state is really big time here. Now, so the question, either he will ask you what is this type of seizure, which I'm not sure. They will ask you these classical ones. I think it's just a classical. The second thing will ask you about the treatment, which is kind of interesting. And it's not so hard. Make it easy, guys. Phenytoin and carbamazepine are the treatment for all of them usually. So you can say tonic-clonic phenytoin, carbamazepine, phenytoin. But usually it's, I don't know which one is better than the other, which I don't think which one is better, but I know for the partial, usually we'll go with carbamazepine. For the partial in general, or for the tonic in general, you'll go with phenytoin. But again, both of them, I will make carbamazepine here, and I will make phenytoin second. And also I make phenytoin and carbamazepine there. I don't think the questions will be which the drug of choice. But protypically, I remember Ideal it's not ideal. Classical questions about seizure, any partial, usually partial complex questions, and they like before, I don't know now, they like just to ask about partial complexes, just carbamazepine is the drug of choice. Valproic acid, where you will see valproic acid is the answer. Could be here too, by the way, tonic, clonic, and myoclonic.